Good afternoon, everyone. I am Dr. Elisa Dayan Soriano, and my topic for today is recognition and initial management of pediatric arrhythmia. These are my objectives for this afternoon. Primary clinically significant arrhythmias are much less common in children compared to adults, and the incidence of clinically significant arrhythmias is estimated at 22.5 per 100,000 pediatric patients. The American Heart Association defines arrhythmia as any change from the normal sequence of electrical impulses causing the heart to beat too fast, too slow, or erratically. Now, when faced with a pediatric child with suspected arrhythmia, especially in the emergency room, it is imperative to secure first the ABCs, the airway, the breathing, and the circulation. And then, you should hook the patient immediately to a cardiac monitor, and we can now get ready to identify a rhythm. Now, I was once a pediatric resident not too long ago, and I know that when tasked to interpret the ECG strip and to identify the rhythm, the residents are also having some sort of arrhythmia themselves. And the resident's rhythm becomes even more abnormal and erratic than your patient's rhythm that you are trying to identify. So I hope that by the end of this postgraduate course, you can self-convert your rhythm to sinus because you are confident enough to recognize and manage pediatric arrhythmias. Now, in identifying the rhythm, we can classify the arrhythmias as having fast or slow rate. Fast rate is called tachycardia, and older patients may complain of palpitations or lightheadedness, while infants may present with irritability. Some may even present as loss of consciousness or syncope. We want to address the tachyarrhythmia as soon as possible so as not to compromise the patient's cardiac output. Sustained rapid heart rate may cause hemodynamic instability, and the patient may present with respiratory distress, signs of shock, or may even have altered mental status. Now, in evaluating tachyarrhythmias, first we need to evaluate the QRS duration if it is wide complex longer than 0.09 seconds or if it is normal or narrow complex with a duration of less than zero point zero 0.09 seconds. If the QRS is less than zero point zero 0.09 seconds, then you may consider sinus tachycardia or supraventricular tachycardia. While if the QRS is more than zero point zero 0.09 seconds, then you might be dealing with probable SVT with QRS aberrancy or ventricular tachycardia. Now, this here is a bird's eye view of the algorithm for pediatric tachycardia, and we will go into them one by one. Again, first thing to do is to secure your patient's airway, breathing, and circulation. Provide oxygen as necessary. Hook the patient to cardiac monitor to identify the rhythm, and monitor the patient's other vital signs like blood pressure and oxygen saturation as well. Obtain a 12-lead ECG if available and feasible. Take note that in any type of arrhythmia, it is highlighted in this algorithm that you should always search for and treat for the possible reversible causes of the tachyarrhythmia. Now, let's go through them one by one. The rhythm is probably sinus tachycardia if you have a compatible history consistent with a probable cause of tachycardia. There is a P wave with a constant PR interval. The heart rate is typically less than 220 beats per minute in infants and less than 180 beats per minute in children. So look at these sample strips. The first one clearly shows the P wave with a heart rate of 115 beats per minute, while the other one has a faster heart rate and the P wave is somewhat difficult to see and is embedded in the T wave. So in sinus tachycardia, the impulse is still coming from the sinus node, but the discharge rate is faster than normal for the child's age. It typically develops in response to the body's need for increased cardiac output or oxygen delivery. So this is actually a normal physiologic response. The heart rate is not fixed and it varies with changes in activity or stress level. So if this is the case, then you must search for and treat the cause of the tachycardia. Rule out infection, metabolic problem, hypovolemia, hypoxia, or other conditions that would require the body to increase its cardiac output. So next, it is probably supraventricular tachycardia or SVT if you have a compatible history wherein the occurrence is abrupt and the P wave is absent and the heart rate is not variable with changes in activity level. The heart rate is usually higher than 220 beats per minute in infants and higher than 180 beats per minute in children. In SVT, the rapid rhythm starts and stops suddenly even without a warning. SVT is an abnormally fast rhythm originating above the ventricles. It is most commonly caused by a re-entry mechanism that involves an accessory pathway or the AV conduction itself. So what do we do now if we are considering SVT? We can try vagal maneuvers first. In infants and children, we can try putting ice water mixture in a plastic bag and apply it to the upper half of the child's face. For older children, try doing carotid massage or Valsalva maneuver by asking them to blow through a narrow straw, especially if the child is already cooperative. Now, while doing vagal maneuvers, get an IV access and instruct the nurse to prepare adenosine at a dose of zero point 0.1 milligram per kilogram, maximum of 6 milligrams for the first dose, using rapid bolus technique. The half-life of adenosine is very short and you want to complete the administration in less than 10 seconds. So give the adenosine rapidly, followed by flushing with 5 to 10 ml of normal saline. So if it fails to convert, a second dose of adenosine may be given. But if this fails again, then we should consider referral to a specialist and we might need to give amiodarone, procainamide, or we might even need to do cardioversion. Now, for wide QRS complex tachycardia in a child with adequate perfusion, consider SVT with aberrancy or ventricular tachycardia. Honestly, it is quite difficult to differentiate SVT with aberrancy and ventricular tachycardia. So, in infants and children, if you see a wide complex tachycardia, treat it as presumed ventricular tachycardia unless the child is known to have aberrant conduction. If the wide complex tachycardia has a uniform QRS morphology and regular R to R interval, and the child remains hemodynamically stable, consider giving a dose of adenosine since it is very effective in the unusual situation of SVT with aberrancy. If the arrhythmia is ventricular tachycardia, the adenosine that you gave will not be effective but will do no harm. At this point, if the patient does not respond to adenosine, consider early consultation with a specialist and we should treat it now as ventricular tachycardia. In ventricular tachycardia, the impulse is generated within the ventricles. Most children who develop ventricular tachycardia have an underlying heart disease or probably has undergone cardiac surgery. Some patients may have long QT syndrome, myocarditis, or cardiomyopathy. Other causes of VTAC are electrolyte imbalance and drug toxicity. Again, we always have to search for and treat reversible causes, obtain a 12-lead ECG, and consider pharmacologic conversion with amiodarone or procainamide. If it does not respond to medication and the child is still hemodynamically stable, consult a pediatric cardiologist before proceeding with synchronized cardioversion. Now, this is a painful procedure, so always sedate the child first. After the child is sedated, start with the initial dose of zero point 0.5 to 1 joule per kilogram. You may increase to 2 joules per kilogram if the first dose is not effective. Remember to always record and monitor the ECG tracing before, during, and after each cardioversion. Now, if you are dealing with a child with a pulse but with poor perfusion and signs of cardiopulmonary compromise such as hypotension, acutely altered mental status, or has signs of shock, then proceed with synchronized cardioversion right away. So now we are done with the tachycardias and the tachyarrhythmias. Again, this is the algorithm that we have just discussed. I would like to emphasize that for all types of tachycardia, always try to search for and treat the reversible causes. Now, let's proceed to the bradyarrhythmias. Bradycardia is when the heart rate is lower than normal in comparison with the normal heart rate range for the child's age and level of activity. Always consider the child's baseline rate and rhythm as well as the level of activity. Interpret the child's heart rate and rhythm by comparing them to the baseline because children with baseline poor cardiac function is more likely to become symptomatic from arrhythmias than children with good cardiac function. Primary bradycardia is because of the heart's inherent conditions that slows down the spontaneous depolarization rate of the heart's normal pacemaker cells, while secondary bradycardia is the result of non-cardiac conditions that alter the normal function of the heart. Bradycardia may be a sign of impending cardiac arrest in infants and children, especially if associated with hypotension or evidence of poor tissue perfusion. Bradycardia in children may be due to sinus bradycardia, wherein the electrical conduction is normal but occurs in a slower rate, or it may be due to the presence of AV block, wherein there is a disturbance of electrical conduction through the AV node. Now, to help you understand the type of bradyarrhythmias better, let me make an analogy that I hope you won't forget. I'm going to tell you a story since we Filipinos are very fond of love stories, right? So let me tell you the different types of bradycardias through the love story of Miss P, who is the lady in red, and Mr. QRS, who is the dashing gentleman in blue. So first up is sinus bradycardia. Sinus bradycardia is a sinus node discharge rate that is slower than normal. It is not necessarily problematic. It may be seen in children at rest when the metabolic demands are low. It may also be seen in athletes with high stroke volume and increased vagal tone. And it may also be seen in response to hypoxia, hypovolemia, hypotension, and acidosis. So, sinus bradycardia is probably the beginning of the love story between Miss P and Mr. QRS. It is not yet necessarily problematic yet. QRS is always there after P. He always shows up, but they are just taking things slow. Now, in first degree AV block, there is a prolonged PR interval representing slowed conduction through the AV node. Patients with first degree AV block are asymptomatic. So here, QRS is still there wherever P is. QRS still constantly shows up, albeit a bit delayed compared to the normal. So the relationship still seems okay with no symptoms at this point. Now, in second degree AV block, there is a block in some of the atrial impulses before reaching the ventricles. In Mobitz type 1 or Wenckebach phenomenon, there is progressive prolongation of the PR interval until an atrial impulse is not conducted to the ventricles. This may be present in some healthy children, but it may also be caused by some drugs or any condition that stimulates the vagal or parasympathetic tone. So as you can see here, the appearance of QRS after P is progressively delaying until one day QRS decides not to show up after P. So in Gen Z terms, this is called ghosting. Now, Mobitz type 2 is characterized by non-conduction of some atrial impulses to the ventricles without any change in the PR interval. This typically results from intrinsic conduction abnormalities. So this is more serious and probably more hurtful than Mobitz type 1 because here there was no lag between P and QRS before the sudden drop beat. There was no premonition that ghosting will occur. Now, last is third-degree AV block, which may be caused by extensive conduction system disease or injury to the heart, including myocarditis, myocardial infarction, or drug effects. Here, no atrial impulses reach the ventricles. So you can see that P and QRS probably is broken up already, and there is no relationship between P and QRS anymore. A pacemaker may be necessary to restore this relationship. So now we go to the pediatric bradycardia algorithm. This algorithm shows us the initial management for a bradycardic child. Like in our tachycardia algorithm, first secure the airway and breathing, give oxygen support, and maintain the patient on cardiac monitor with BP and oximetry monitoring. It is ideal to get a 12 lead ECG, but do not delay therapy or management. If there is cardiopulmonary compromise, such as hypotension, altered mental status, or signs of shock, and despite adequate oxygenation and ventilation, the heart rate is still less than 60 beats per minute in a child with poor tissue perfusion, you may now begin chest compressions. If there is no cardiopulmonary compromise, continue supporting the airway, breathing, and circulation. Look for causes of the bradycardia and refer to a specialist if necessary. Now, if the bradycardia persists, you may now give medications such as epinephrine and atropine. For complete heart block, you may consider pacing. If pulseless arrest develops, then proceed to the cardiac arrest algorithm and begin resuscitation. So I hope you learned something today. Thank you. That ends my lecture, and thank you very much for listening.